Good afternoon and a warm welcome to all the respected doctors who have joined us this busy afternoon and for the yet another session in the series of Neffron. To set the context, I would like to share that Neffron is an educational initiative of Saffron that involves the experts in the field of nephrology to share their expertise on different topics of chronic kidney disease management that can help in the early detection and the right treatment of the disease. And today, we are very fortunate to have with us Dr. Sharad Sheth with us as a clinical expert. Dr. Sharad Sheth is the head of Department of Nephrology at Kokilaben Dhirubhai Ambani Hospital in Mumbai. He has done his MD in General Medicine at Bombay University and secured the third rank. And he has passed his MNAMS in nephrology in the year 1981 from All India Institute of Medicine, New Delhi. He has a rich experience of total 39 years in the field of nephrology. Apart from this, he has also experience in the field of teaching. He has successfully carried out more than 600 live kidney transplantation in the past 40 years and more to come. He has many national, international publication under his name and has also been a esteemed speaker in various prestigious conferences and forums. So with this, now I would like to welcome Dr. Sharad Sheth to take over the session and guide the doctors who have joined us today.
Thank you, Anjali, uh, for a kind introduction. I shall be talking on the need of alpha ketonolog in the management of CKD. Slide.
Ma'am, is it possible to share from your end?
Yeah, sure, I'll share that across.
So by the time if you say send,
Yeah,
second
I'll say
slide,
next. Yeah.
yeah, that will be good.
Hmm.
I've shared the slides, sir. You can go
Yeah.
ahead.
Yeah. Go to the next slide, please. Okay. So chronic kidney disease prevalence 850 million people affected worldwide. The burden of kidney failure is increasing in India with 210,000 new cases being diagnosed each year. CKD in India is often diagnosed late and in the early age as compared to the Western country. And lack of awareness often plays an important role, and the absence of symptoms, higher incidence of interstitial nephritis, and CKD of unknown origin contributes to the delay. Next slide. So, challenges with the management of CKD, delay in the treatment due to delay in diagnosis, progressive nature of CKD leading to ESRD, malnutrition, and protein energy wasting. Next slide. So, the goal of treatment in CKD is to prevent or slow down further damage to the kidneys, maintain overall health, reduce the toxins and nitrogen load, balancing the intake of energy, protein, sodium, potassium, phosphorus with biological markers and weight change. So, dietary intervention is a mainstay approach in CKD management. Next slide. So the introduction of keto analogs of amino acids are nitrogen-free analogs of essential amino acids. They get transaminase in the body from essential amino acids, reduce uremic toxin load, and correct amino acid deficiency and delay dialysis. Next slide. So the mechanism of action is transamination to essential amino acids. The keto alpha keto acids are converted into essential amino acids by process called transamination using available non-essential nitrogen sources. This process reduces the need for dietary protein intake while ensuring adequate protein synthesis. So reduction of nitrogenous waste. Unlike dietary proteins, alpha keto analogs do not release additional nitrogen during metabolism. This reduces urea, ammonia, and other nitrogenous waste, decreasing the workload on the damaged kidneys. Next slide. So the mechanism of action, this is an important slide. The keto analogs of essential amino acids, which are deaminated, they accept aminase or from nitrogen waste products, and these nitrogen waste products are derived from protein and amino acid metabolism, and they also release energy, glucose, fat, and non-essential amino acids. So ultimately the keto analogs of essential amino acids, which are deaminated, accept, get transamination and get converted into essential amino acids, which are required by the body for positive nitrogen balance and for formation of neurotransmitter, hormones, growth of muscle, and other cellular processes and enzymes. Just to recapitulate, what are these essential amino acids that the body needs? They are arginine, valine, isoleucine, leucine, lysine, histidine, methionine, phenylalanine, tyrosine, and tryptophan. So these are all names of essential amino acids which get synthesized or produced in the body from keto analogs of essential amino acids without generating nitrogen waste like urea and ammonia. Next slide. And uric acid. So composition, the alpha keto acids corresponds to specific essential amino acids. For example, alpha ketosocaprioic acid is the alpha ketonologue of leucine. I said again, I'll repeat all the essential amino acids: histidine, isoleucine, leucine, lysine, arginine, valine, methionine, phenylalanine, tyrosine, tryptophan. All these essential amino acids have the specific corresponding keto acids or keto analogs, which get undergo transamination and synthesize essential amino acids in the body. Often these keto acids are bound to calcium salts to improve their stability and absorption. But this does not lead to increase in calcium load in CKD patients because most of the CKD patients are deficient in calcium. So essential amino acids, in addition to keto acids, sub-formulations also include essential amino acids themselves, such as lysine, threonine, tryptophan, histidine, and tyrosine. Next slide. So some of the preparations have both keto analogs and essential amino acids. But we need double strength. Why? Both strengths contain the same essential amino acid precursors and work through the same mechanisms, but they cater to different patient profiles, dosage requirements, and compliance challenges. Next slide. The biggest challenge with this product is the compliance because a lot of pills are required and there is a pill burden to the patient. In order to reduce the pill burden, we need to have double strength. So CKD stage 3-4 with dietary protein restriction and elderly patients with reduced dietary intake, single strength, and double strength CKD stage 4 and 5 with rapid GFR decline, malnutrition, post-transplant or post-cardiac surgery, patients with poor adherence to high tablet load. Next slide. So the dosage and administration, actually it is 1 tablet per kg of body weight. So if a person is weighing 60 kg, he needs to take 12 tablets a day, which is a very heavy pill burden. So then we have this double strength, which is per tablet for 10 kg. So in a 60 kg, instead of 12, we need to give 6. So this improves the compliance of the patient. Divide into 3 doses with meals to support the absorption. Always give with meals for transamination benefit and combine with dietitian supervised low protein diet or very low protein diet. Low pill burden, half the number of tablets with double strength, and should still be administered with meals for the benefit of transamination. Next slide. So overview of clinical benefits: it slows the progression of ESRD, reduces urea, creatinine, phosphorus, uric acid, ammonia, improves serum albumin and nutritional markers, delays dialysis, improves quality of life in pre-dialysis patients. Next slide. So clinical trial summary, there are various studies published in JASN and Nephro transplant in 2016, 12 and 9, and all these studies mainly included keto analogs of essential amino acids with low protein diet or classically very low protein diet. That is, low protein is 0.6 gram per kg and very low protein is 0.3 gram per kg. As it is, we most of the Indians are vegetarians and we always already have low protein in our diet. So LPD 0.6 gram per kg is our usual conventional diet. But if we further restrict protein intake, then it becomes very low protein diet. So its GFR declines slower, minus 1.8 versus minus 3.4 ml per minute per year, and it improves albumin and phosphate, delayed needs for dialysis. Next slide. And they are very well tolerated and they don't have any adverse side effect. So 2020 KDIGO and KDOKI guideline recommends keto analogs of with low protein diet, that is 0.6 gram per kg per day, to prevent progression and maintain nutrition and prevent malnutrition. Next slide. They also get benefited in reducing CRP. So it improves the inflammatory part also. So the key takeaway of practice: effective in slowing CKD progression and delaying dialysis, helps to reduce urea, creatinine and phosphate levels. Next. Supports nutritional status without adding nitrogen load, backed by RCTs and real world studies, and recommend low protein diet, that is 0.6 gram per kg per day. Next slide. So they are available as both single strength and double strength. If you want to reduce the pill burden, you go to double strength. The only problem issue is the size of the pill is big. So sometimes you may break the pill into 2 or 3 or 4 and take it. So always administer with meals to enable transamination. Next slide. They are safe for use in elderly, diabetic and high risk CKD patients. Next. Well, thank you very much with this, and I shall be willing and happy to answer questions if there are any.
Thank you so much, sir, for a very crisp and comprehensive presentation. There are few of the questions, sir, which were earlier shared by our physicians and they wanted to ask you during the session. So I've just noted down those questions and I would like to ask you that. Sir, at what stage of CKD do you prefer to initiate alpha keto analog in the therapy?
Yes, when the GFR goes below 60, it is CKD stage 1 where GFR is more than 90. Stage 2 is 60 to 90. So in between, at the end of the stage 2 or beginning of stage 3, that is the stage wherein we need to add keto analogs. And produce protein restriction to 0.6 gram per kg per day to delay or slow down further progression of kidney damage.
So, is there any other indication apart from CKD where alpha keto analog can be used? There was one question from the chat that has come.
I don't know of any other indication apart from CKD. At least I'm not aware of that.
So, do you recommend this to diabetic CKD patients or
Yes,
elderly patients
yes,
wherever there is a nutritional deficiency?
very much, very much. As I said, this delays need for dialysis, slows down further progression of renal disease, and it prevents malnutrition and muscle wasting or sarcopenia.
So, are there any clinical or biochemical markers that you notice while starting this alpha keto analog therapy?
So we may measure serum albumin or pre-albumin, and that would indicate malnutrition. And we need to supplement and prevent this with keto analogs of essential amino acids.
So, any important dietary counseling given to the patient, especially because in India there are varied types of people and they take non-vegetarian food as well. So, anything like related to the dietary recommendation that you suggest with the keto analogs?
Yes, yes, very much. That's the benefit of keto analogs, that we need to educate them to restrict their protein intake in the diet. So non-veg, almost no for non-veg, and vegetarian proteins also, we need to tell them to reduce the quantum of vegetarian proteins.
And so, for the patients who are already in the therapy of keto analogs, what is the way where we can measure the progress of the patients after taking the keto analogs therapy?
We have to measure EGFR, estimated GFR, EGFR, to estimate the further progression of CKD.
So, would you like to share any of the thoughts with regard to delay in the dialysis of CKD patients while alpha keto analog is being given?
Very much. You know, when I was student a couple of years back, we didn't have all these drugs in our armamentarium. And I was taught when I was student, that is about 30 years back, that CKD staging from 1 to 5 indicates that eventually a person who is in stage 1 or 2 eventually progresses to the stage of 5 and goes on dialysis. Now a day has come wherein we have multiple nephroprotective modalities by which we can slow down or stop or arrest further progression of renal disease. If a patient has come to me with CKD stage 3, as I said, early part of CKD stage 3, GFR is just little less than 60 ml per minute. With the help of RAS blockers, SGLT2 inhibitors, GLP receptor analogs, non-steroidal mineralocorticoid receptor antagonists, probiotic, pre-probiotics, and keto analogs of essential amino acids, we can prevent further progression of renal damage and prevent patients from reaching stage of dialysis or end-stage renal disease, which was not so earlier.
So, there are like different opinions regarding the keto analog therapy. So, like, what do you suggest the young physicians and the young nephrologists with regard to this in the early detection as well as, taking care of the nutritional therapy of the patients?
No, this is very much documented. It's endorsed by KDIGO and KDOKI both. That if you resort to low protein diet or very low protein diet, you need to supplement with keto analogs or essential amino acids to prevent malnutrition, which is very common in CKD patients. And because they already have nausea, vomiting, their food intake is less, and we need to, these are essential drugs, we need to supplement. The only issue is the cost. And probably if cost effective benefit of this drug, ultimately if a patient reaches dialysis, then he spends so much money on dialysis or kidney transplant. At least you can prevent them from progressing to that stage by giving this particular drug in time. So
Rightly said, sir.
overall it is very much beneficial.
Yes, sir. So one last question was regarding the double strength. This has been a new introduction in the alpha keto analog therapy. So what is your take with regard to this? And if you have been using it in your practice, which are the patient profile where it can be more beneficial in?
No, I said in my talk, CKD stage 4 and 5, wherein the number of tablets matter a lot. You see, if you have to give phosphorus binders, if a person is on Sevlamar, is already consuming 6 tablets a day. In addition, if he has to consume 12 tablets of keto analogs a day, if he is a 60 kg, it is almost futile. I mean, very difficult. Plus, they need iron supplements, vitamin supplements, and soda bicarb, antihypertensives, anti-diabetics. Just see the list would go to about 20, 25 tablets, more than that a day. So, in order to cut down the pill burden, it is the double strength is welcome.
Thank you so much, sir, for addressing most of the questions from the audience. And with this, we come to an end of the session. If there are any questions, I would suggest all the participants to share on the chat as well. On YouTube, also we are live. So if in case there are any question that can be addressed on YouTube as well, we can take it up with Dr. Sharad Sheth. So, with this, I would like to come to the end of the session. And on behalf of the entire team of Saffron, I would like to thank Dr. Sharad Sheth for joining us for a very short while, yet, taking some time out from his busy schedule and guiding all the physicians and the doctors who have joined us today regarding the need of alpha keto analog in CKD management. Thank you so much, sir, for your time. And we have this recorded session live on YouTube, and we will be also sharing it to you for the benefit of other doctors as well. So, thank you so much, sir, for joining.
Thank you, Anjali. Thank you,
Thanks a lot.
everyone. And thanks to all the participants who have also spared their time to listen to me. And
Thanks a lot. Thanks.
thank you, Abhishek, also.